Hey everyone, welcome back to the SEMS conference podcast. Today I'm joined by Dr. Carles Pedret, a sports medicine physician and MSK sonographer based in Barcelona, who advises elite clubs across Europe and North America on muscle and tendon injuries. At SEMS 2026, he's presenting his talk, Imaging Thigh Injuries from Diagnosis to Decision Making. Carles, thank you so much for joining me.
No, thanks to you.
Yeah, no, thank you so much. So, your talk is on imaging thigh injuries from diagnosis to decision making. Where do you see clinicians most commonly getting the decision making part wrong, even when the imaging itself is read correctly?
Yeah, so I think that the main problem that we have now with imaging is that some people trust completely in imaging and some people don't trust in imaging at all. And we need to understand that this is a world of grays, not a black and white. Okay, so I think that we need to put imaging in the right position. So imaging is key for a initial diagnosis of injuries, and that's probably the most important thing that we need to do, because if we don't know exactly what we need to treat, it's impossible to manage that correctly. Okay, so I think that imaging is key in the beginning of the process, and then I understand that there is some controversial in people that, like me, I like to have imaging every 3-4 weeks to see the quality of the scar tissue and understand if we can push a little bit more or we need to delay the process a little bit more than normal, not to stress the area and to prevent re-injuries. And there are other people that they just go through clinical symptoms until the final return to play. Everything is fine, but we need to understand why are we doing any of those things.
Exactly. So, in your strategy, you would combine imaging alongside the descriptive symptoms the patient, the athlete is experiencing, and you would create and diagnose from both those points, and then frequently monitor that those images rather than just take one image, at the start and then one image maybe 6 to 8 weeks later.
Yeah, that's for sure. So the way I work is in the first 72 hours, always speaking about professional athletes. So then with amateur athletes, we can manage that timings a little bit more normal. But in professional athletes, we need a very accurate diagnosis in the first 72 hours. So I perform an MRI scan, and if it's possible, also an ultrasound scan in these first 72 hours. And that give us a very accurate diagnosis if the images are correctly seen and correctly interpreted. Okay. The thing is, sometimes clinical symptoms doesn't show the magnitude of the injury. For example, the most dangerous or bad prognosis injuries are intramuscular tendinous injuries, and that ones, in the moment, they hurt a lot, but after 24 hours, 48 hours, they don't feel almost anything if we don't stress the specific area. So clinical symptoms are very good in the process, but mainly initially, we need to trust more in the MRI diagnosis, especially MRI, ultrasound as well. But for a very accurate diagnosis from the beginning, we need probably an MRI. And not only this, because people think that we just put the player into an MRI device and everything is fine and everything goes well. No, we need the correct protocol. We need the correct interpretation of the images. We need the correct understanding of the injury mechanism and where the injury is. So it's not that easy of just making an MRI.
Right, right. So you're combining the ultrasounds, the ultrasound-guided procedures, and the MRI in your assessments. Generally, for a muscle and tendon injury, would you reach straight for an MRI or would you maybe go for an ultrasound first?
If it depends on me directly, so I have the player here, I do an MRI scan and I do an ultrasound scan, because it's not about what is best. It's better the ultrasound or it's better the MRI. That's a nonsense. So every imaging test can give us different types of information, but it is true that for the assessment of the dense connective tissue structures, which are the most important ones in terms of prognosis, the MRI, it's much more accurate at that point. Okay.
Yeah, exactly.
Then once we have an accurate diagnosis from the beginning, we can plan a, a tailored return to play process. And then is when it comes not only the imaging, but also the clinical testing, the strength testing, the gene testing, the field testing, the GPS data, and it's all progressing along the weeks or along the month, depending on the injury.
Yep, exactly. And there's nothing athletes love more than getting a quick and accurate diagnosis so they know what kind of cross training they can do, what their weaknesses are, and, of course, return to doing what they love sooner. So that moves me neatly on to the next question, which you've kind of just answered in the past one, but I will ask it anyway because I'm sure you have more to add. Your workshop title moves from imaging straight to readiness. How directly does an imaging finding actually translate in a return to play decision in your experience?
Yeah. So what we have seen, and we published that several papers about that, imaging can give us the information about the quality of the scar tissue. So it's unavoidable to have a scar tissue once we had a rupture. Okay. And we need to monitor this scar tissue. Okay. Because we know the stages during time. We know that there is an acute injury there. Then there is a soft scar stage, which is a very weak and a very weak stage in the scar. Then it goes an hypertrophic scar that it's getting then mature from the peripheral part to the center part. And finally, we have the adaptation process of this scar. Okay. So if we have an imbalance between the load applied and the maturation of the scar in the late stages of the return to play process, here in this gap is where we have a high re-injury risk, because the scar tissue is not enough mature in terms of imaging, but everything in the gym works correct, and clinically the athlete is perfectly fine. So we just continue loading and loading and loading until the scar tissue is stressed so much and have a re-rupture. So we need to balance that, the scar tissue maturation and the load applied, more or less. It cannot be a big difference. So that's what we measure and what we monitor with, especially with MRI, but also we can do that with ultrasound scan.
Right. And so you're having athletes come into your clinic across football, basketball, American football, baseball, and ice hockey even. Seeing all these athletes and teams, what's a common misread or overread on imaging that you see happen often, and what should clinicians be more skeptical of?
I think that we need to be more objective. So I understand that every single professional athlete wants to return soon. Okay. But sometimes there is no chance to return soon. So we need to be very objective, although everyone is pushing us. And sometimes we need to follow the timings and the biology. So it's not a matter of I am a very good physician because I put the players sooner than anyone in the field. No, it's just a matter of risk and benefit all the time. So I'm not bad than anyone if I delay the return to process 2 weeks. Probably I see some risk factors that makes me think that way. Okay. But then, for example, if it's a World Cup final or a Champions League final, we can get through that risk and push the player and say, okay, then if we have a problem, we will deal with that. But if everybody understands the risk, you can push. So it's not a matter of how good I am. It's a matter of how much risk I'm ready to take. And this is probably the thing that every clinician should understand. And to be able to do that, you need a lot of knowledge about a lot of areas in the sport, about the athlete, about the injury, about the process, about everything, so you can manage that risk. And I don't know if I answered the question you asked, but
You did, because of course, especially if you're in a team-based sport, everyone wants the athlete back, as you said, but at the end of the day, once you're injured, and it's more about the health before the athlete, because there's health, and then you can be the athlete
Yeah,
beyond
but,
that.
but it's even more than that. So sometimes you push an injury, and as I said, it's like rolling dice, and you push that injury, okay, and you can get through that. But the athlete, for example, doesn't feel 100% comfortable with that, and he starts compensating with another region. So he
Mhm.
overloads that other region, and 2 or 3 weeks later, he has a small injury in that other region. And then you can see through the season players that starts with a big injury during the preseason period, and then they go through injury to another injury all the season. And this is because compensation, and because they never get completely well of any of those injuries that they have. So it's better
Yeah.
to delay the process, to readapt the whole muscle group functionality, not only the injury itself, but also the functionality of the whole muscle group. Delay the process 1 week, 2 weeks, that rather than going from injury to injury during the whole season until we can make a big reset again.
Yeah, at some point you have to break the cycle. It's just, of course,
Yep.
that you've always got the emotional challenges of that, which come with the job. So a lot of respect. And as someone who's teaching across several countries, is there a gap between what the evidence says, in all the research, and what's actually being practiced on the ground?
Yeah, we could speak about that for hours, because science right now is getting very, very close. So everyone can publish almost everything, because there are a lot of journals, a lot of people doing a lot of things. But we need to be careful first with everything that is published, okay? And second, we also need to follow a little bit our experience in that area, okay? So it's very difficult sometimes to put on the field something that it's almost just in the paper. So I always say that the excellence is coming from the evidence plus the experience, okay? Not only the experience and not only the evidence, but again, you have a very critical mind and a very critical way of thinking to see what can you apply from what is published and what is still not ready to apply, or simply it won't be applied never, okay?
Right.
And it's just theoretical, just to think about. But for that, you need a very good basis of understanding about physiology, histology, biology, to know if that's correct or it's just a publish for publishing.
Yeah, there's plenty of papers out there, and anything less than a significant number, like the people volunteering or involved in the study, then it's hard to even ensure that the study's reputable to even use in the clinical practice. But because there is so much information out there, because we are in the age of AI, things
Yep.
are a little more complicated. People using Dr. Google more than ever.
Yeah. And that's why I said that we need to be very critical. And to be very critical, we need to have a very good basis. And that's why in recent years, I try to start my speeches and everything coming from the anatomy, the histology, and the biology. Because if we stand this, it's very difficult not to be critical with all the rest. You stand the biology, you stand the physiological process of the healing after a muscle injury, you understand the cells, how they work. If you understand that, it's much more difficult to be tricked by some research or some fancy, I don't know, devices or whatever you want to say. That you need a correct basis for that.
Right, exactly. And so coming into the SEMS conference, and you just mentioned that you'll start your talk with what we just chatted about. What are you most looking forward to? And in delivering both the imaging talk and the muscle injuries workshop, what will be your key focus or message? You can say it briefly because we don't want to give your workshop away. We want to have some anticipation. But yeah, talk to me a bit about that.
Yeah, but I think I have to speak about thigh muscle injuries, and this is mainly hamstring and rectus femoris, and I have 20 minutes. So it's a very short period to speak about all the injuries. But what I will try to do is to show where people can find injuries in professional sports in all the muscle groups and the prognosis of that injuries in general, understanding the kind of tissue affected, understanding the injury mechanism, and understanding the dense connective tissue is affected or not. So I will try to say, okay, in RegFem, you can find these 7, 8 types of injuries, and the prognosis it's in that way. Then obviously you can find a lot of combinations. And also in the hamstring, you can find these all 7, 8 different types of injuries in professional sport. You need to understand which one are most dangerous than other. And that's pretty much what I will try to do in 20 minutes.
For those of you listening, Carlos is presenting on day 1 at lunchtime, and his workshop is Imaging Thigh Injuries from Diagnosis to Decision Making. This isn't one to miss. He is covering the key areas to look for injuries and how to diagnose these properly. So this is a must attend. The conference is on the 1st and 2nd of October, and tickets are still for sale. Thank you so much for speaking with me today. I really appreciate it.
No, thanks to you. It was a pleasure.